Welcome to this explainer. Today, we're jumping right into a truly fascinating biological phenomenon: what happens when you pull the plug on the body's ultimate biological switchboard. We are talking about cholinergic antagonists, basically a class of chemical agents that perform the ultimate biological intercept. If you've ever wondered how doctors can safely paralyze a patient for a delicate surgery, or how a single tiny patch can completely erase motion sickness, well, you are definitely in the right place. So let's dive right in and see how these incredible interceptors actually work.
To keep us from getting lost in a maze of complex drug names, here is our roadmap for today. We'll be hitting 1. Intercepting the body's messengers. 2. The organ blockers. 3. System interruption. 4. Muscle paralysis. And finally 5. The power of blockades.
All right, Section 1. Intercepting the body's messengers. Let's set the stage. To really grasp this, imagine the neurotransmitter acetylcholine as a relentless, high-speed messenger. It's constantly firing signals across your nervous system to your internal organs and your skeletal muscles. It's telling your heart to slow down, your digestive system to get to work, your muscles to contract. It is the primary driver of your parasympathetic nervous system, your rest and digest mode. But what if we could intercept those messages before they ever reach their destination?
Well, that is exactly what a cholinergic antagonist does. These agents bind to specific receptors, namely muscarinic or nicotinic ones, and they just sit there. They completely block acetylcholine from doing its job. The crucial takeaway here is that by utilizing these antagonists, the parasympathetic nervous system is entirely interrupted. And when you shut down that rest and digest side, the sympathetic nervous system, your fight-or-flight mode, is left completely unopposed. It's basically like taking the brakes off a car while the accelerator is still pinned to the floor.
We can organize our interceptors into 3 clear squads, basically based on where they set up their blockade. First up, the antimuscarinics, which target internal organs. Next, the ganglionic blockers, which hit the main autonomic hubs. And finally, the neuromuscular blockers, which go straight to the skeletal muscles. We're going to unpack each of these 3 squads right now.
Moving right along to Section 2, antimuscarinics, or as I like to call them, the organ blockers.
Clinically speaking, these are some of the most useful interceptors out there. 2 of the absolute heavyweights in this family are atropine and scopolamine. Both are actually naturally occurring plant alkaloids. They share a ton of similarities, but they have one massive difference in how they act inside the body. Atropine mostly acts peripherally, meaning it affects the body's organs but doesn't cross into the brain very much at standard doses. Scopolamine, on the other hand, it easily sneaks right across the blood-brain barrier into the central nervous system. Because of that, scopolamine is incredibly effective at preventing motion sickness. It even has the rather wild side effect of blocking short-term memory, which just goes to show how profoundly it interacts with the brain.
Now, what is truly fascinating about atropine is how it behaves depending on the exact dose you give. It is highly, highly dose-dependent. At a very low dose, it might just give you a slightly dry mouth and maybe slow your heart down a touch. But as you increase the dose to a moderate level, the blockade really intensifies. Your heart rate shoots up and your pupils dilate wide open. Push it to a high, toxic dose, atropine crosses from peripheral symptoms into central ones, causing hallucinations, delirium, and eventually even a coma. The body's response just completely escalates.
And speaking of pupil dilation, get a load of this number: 14. That is the maximum number of days a single topical drop of atropine can keep your pupils dilated. 14 days. It brilliantly illustrates why eye doctors completely abandon it for your routine eye exams. Seriously, imagine going to the optometrist and having to wear those flimsy, dark paper sunglasses for 2 straight weeks because your pupils are locked open. No thanks. Today, shorter-acting synthetic versions do the exact same job but wear off in just a few hours.
Before we leave the organ blockers behind, we have to mention a brilliant piece of modern pharmacology: ipratropium and tiotropium. These are derivatives of atropine, but they've been chemically engineered to carry a positive charge. Why does a positive charge matter? Because it means they cannot absorb into the systemic circulation or cross into the brain. You inhale them directly into the lungs, and they stay exactly there, totally isolated. They block the muscarinic receptors in the airway, forcing the lungs to dilate, making them absolute lifesavers for patients suffering from COPD and severe asthma.
Okay, on to Section 3, ganglionic blockers, which are all about total system interruption.
When we talk about ganglionic blockers, we basically have to talk about nicotine. Therapeutically speaking, it's a poison with zero medical benefit, but mechanically, it is a fascinating case study in biological extremes.
At lower doses, nicotine stimulates the ganglia. It triggers a release of dopamine and norepinephrine, causing pleasure, arousal, and a spike in blood pressure. But at high doses, it essentially short-circuits the system. It depolarizes the ganglia and then just stays there, causing a massive blockade and complete paralysis of the ganglia, leading to a dangerous plummet in blood pressure. It literally flips the switch on the entire autonomic system.
That brings us to Section 4, neuromuscular blockers, which means we are talking about muscle paralysis.
These drugs bypass the organs and autonomic hubs entirely, interfering with transmission right at the skeletal muscles themselves. And there are two vastly different ways to paralyze a muscle pharmacologically. First, we have non-depolarizing blockers. These are competitive. They sit on the muscle's receptor like a cap, just preventing acetylcholine from binding, but they don't stimulate the muscle at all. They just block it. On the other hand, we have depolarizing blockers. Think of these like Trojan horses. They mimic acetylcholine perfectly, causing the muscle to fire, but then they stubbornly refuse to let go. The muscle can't reset, which ultimately results in total paralysis.
The history behind those non-depolarizing blockers is absolutely amazing. It's incredible to think that modern surgical anesthesia actually evolved directly from curare. Native Amazonian hunters originally used curare on the tips of their blow darts to paralyze their prey. Scientists took that precise competitive blocking mechanism, studied it, and refined it into the ultra-safe neuromuscular blockers used in modern operating rooms today to keep patients perfectly still during delicate surgeries. Talk about a wild origin story. But managing that paralysis, it's a very delicate art. Anesthesiologists can cleverly reverse these competitive intercepts by using drugs called choline esterase inhibitors. These inhibitors flood the junction with extra acetylcholine, effectively washing away the blocker. However, they have to carefully navigate a serious minefield of drug interactions. Things like inhaled halogenated anesthetics, certain strong antibiotics, and even standard calcium channel blockers can all dangerously enhance the paralysis, making it much harder to wake the patient's muscles back up.
Now, let's look at the other side of the coin, succinylcholine. This is the only depolarizing muscle relaxant we still use today. Remember that Trojan horse analogy? When you administer succinylcholine, it hits the muscle receptors and forces them to fire. This is phase 1, which actually causes the patient's muscles to visibly twitch and spasm for a brief moment, a process called fasciculation. But because succinylcholine won't let go, the receptor rapidly desensitizes. This leads straight into phase 2, where the muscle becomes completely unresponsive, locking into total flaccid paralysis.
Now, succinylcholine works incredibly fast, which makes it the absolute go-to drug for emergency situations where a doctor needs to intubate a patient immediately to secure an airway. But this interceptor carries severe, sometimes life-threatening risks. Some patients have a genetic deficiency where they lack the specific plasma enzyme needed to wash the drug away. For them, a brief paralysis turns into prolonged apnea, where they can't breathe on their own. It can also trigger malignant hyperthermia, a rapid, dangerous rise in body temperature. And finally, because of how it forces the muscle to depolarize, it causes cells to dump potassium into the blood. In patients with massive tissue damage, like severe burn victims, this sudden spike in potassium can be instantly fatal to the heart.
Finally, let's wrap things up with Section 5, the power of blockades. Mastering the power of the blockade matters immensely in real-world medicine. It creates the ultimate pharmacological juxtaposition. On one hand, you have high-dose atropine, utilizing its blocking power as a literal antidote to save a farmer from deadly insecticide poisoning, or even a soldier from a nerve gas attack. It steps in to block the deadly flood of acetylcholine. On the other hand, you have neuromuscular blockers using that exact same concept, interrupting the messenger, not as an antidote, but as a controlled weapon to completely paralyze a patient so a surgeon can perform life-saving orthopedic surgery. It is all about mastering the intercept.
As we wrap up this explainer, seeing how effectively we can manipulate these receptors leaves us with a pretty profound question. If we can so completely master the blockade of the single messenger, acetylcholine, to safely freeze muscles, speed up hearts, and dilate lungs, what other vast biological switchboards in the human body are just waiting to be intercepted? The future of targeted medicine is all about finding the right switch and knowing exactly when to pull the plug.